Welcome to our Primetime Alive program, Protecting Your Vision as You Age. I am Vicki Newell. I manage the Primetime Alive program here at Mary Greeley Medical Center. As a reminder, if you want to sign up for a program or join Primetime Alive or watch a recording of a past program, you can go to our website, mgmc.org/PTA. Our presenter today is Dr. Nicole Morrow. Dr. Morrow is originally from Cedar Rapids. She received her Bachelor of Science from Mount Mercy University, and then she received her medical degree from the University of Iowa College of Medicine. She completed her general surgery internship and ophthalmology residency at Vanderbilt University Medical Center in Nashville, Tennessee. While she loved living in Nashville, she was ready to come home to Iowa and joined McFarland Clinic in September 2024. In her free time, Dr. Morrow enjoys staying active, spending time with her friends and family, and her fur baby, Bruce. Please welcome Dr. Morrow.
All right. I think it's on. Yeah, okay. Hello, everyone. I'm Dr. Nicole Morrow, and I'm here to talk about your eyes as you age and give you some tips to kind of keep your eyes healthy as you get older. I like to start saying I have no monetary or financial interest in any product, medicine, or material discussed. And the material discussed today is for educational and informational purposes only, and it's not a substitute for professional medical advice, diagnosis, or treatment. I am going to talk about these topics today during our talk, so save all your questions and we can go a little bit deeper into any of these topics as we get to the end. I wanted to begin today with some basic eye anatomy to help orient everybody. Okay, good, my laser pointer's working. So starting here in the left photo, obviously this is an external photo of the eye. The white part here is called the sclera, and then there is a clear covering over this called the conjunctiva. You then have your colored part of your eye right here called the iris. That's this part right here. And then your cornea, which I like to call the windshield of the eye, is this part, this clear covering, and it's in front of your iris or the colored part of your eye. Here is an internal photo of the eye. This orange part is your retina, or like the film, and that's what processes all the light and information that you're seeing in the world. You can also see your veins and arteries here. So you have very small veins and arteries in the back of your eye that we're able to see when we look inside. And then this right here is called the optic nerve, and this is the cable that connects your brain to your eye. And then finally, this right here is your lens. It sits right behind the iris, and it's clear when you're born, and this is what becomes a cataract as you get older. These are some of the classic terms we use when we're describing types of glasses that people need for correction. The first one is what we call nearsightedness, and then how I describe it, I'll say myopia. So these are people who have negative glasses prescriptions. They can see really well up close, but the distance is pretty blurry without correction. The opposite of this is called farsightedness or hyperopia. These are the plus prescriptions, and these patients can see sometimes pretty well in the distance, but need some glasses for reading up close. And then an astigmatism it refers to the shape of your cornea. So you think of that clear covering of your eye. Not everybody's eye is perfectly spherical, like a ball, like a basketball or a soccer ball. It's usually a little bit more oblong, like a football. So you have a flatter part and a steeper part. And so when people have an astigmatism, sometimes we have to use that in the glasses to correct for that. Now, if you go to an optical shop, the opticians can help personalize prescription eyewear that suit you best for your daily needs, that fit your face and have everything that you need in them. Additionally, we can fix these corrections with contact lenses for some patients. So presbyopia, and that just means that you need reading glasses. This begins around the age of 40 for most patients. It's where your eye starts to lose your near focusing power. The first thing people realize is that they need to hold things further away from themselves to be able to focus, because you're not able to pull things up as close as you once were. This is not preventable. This is very normal with aging. Some people who don't typically wear glasses can just buy over-the-counter pair of readers and they can pop those on. When you first start noticing this, you're usually at a lower prescription, and as your ability to have that near focusing power continues to get worse, you need to have a little bit stronger reading aid. Now, we can also put this prescription into glasses for people who wear glasses on a daily basis. You may have heard in the advertisements of Vuity or Viz. These are prescription dry eye drops that help with low levels of presbyopia or helping with reading up close. What they do is they make your pupil, that dark part of your eye, smaller, and that actually allows you to read a little bit up close. So for presbyopia treatments, the way we can add them to glasses, we can do bifocals, trifocals, or progressives. Those are probably classic terms that everyone has heard of, or they refer to them as lined or unlined. So if you have a lined glass like this here, so this right here will be the distance, and you'll have a line here, and then this is your reading. If you have a trifocal, this is the distance, this is like a computer distance, and this is your near distance. And so these glasses will have a visible line on them, and you can see exactly where you need to look to be able to hit where you need your reading aid for. These top up here are just different types of lined bifocals. Now down here is progressives or unlined, where they do not have a line specifically on the glass. It's more of a blended reading power. Whereas you go here, you have distance, your computer distance, and then you get down to your near when you look down through the bottom of the glasses. Now, each of these glass options are very good options for people. It really is patient dependent on what they feel is going to best suit their daily life. Now, we can do similar things with contact lenses. So there's something called multifocal contact lenses, where in the contact lens, there's a zone where you look through that have your distance zone, intermediate or computer zone, and near zone. And some people can have those to have no glasses and still have the reading power. And then other people will sometimes do what we call monovision, where we set their non-dominant eye to read up close, and then their dominant eye we set for distance. So they get a little bit of both that way. Now, some people don't like either of these options, and they opt to wear their contact lenses, set for distance, and then they just throw on over-the-counter readers over them. So we're going to kind of dive into the common eye problems. One of the most common eye problems that I see on a daily basis is dry eyes. I always say dry eyes is a chronic process that we don't cure, but we can treat the symptoms. It's very, very common in the general population. The typical symptoms that people will say will be stinging, burning, grittiness. You can even have excessive tearing, which sometimes doesn't make sense, but your cornea has one of the highest concentrations of nerves in the body. It's one of the most densely innervated organs or tissues in the body. So therefore, when your cornea or that surface of your eye is dry, it tells your tear glands, I need to make more tears, therefore you tear. People can have red irritated eyes. You can increase blinking because you're trying to windshield wiper that cornea to disperse your tears over it. You can also have fluctuating vision. If you go back to my windshield analogy, if you think of the cornea like a windshield, when it's dry, it's like a dusty windshield, and you need to blink and windshield wiper it away to kind of clear it up. These are kind of the classic symptoms we see for that. Now, what causes it? There can be a variety of causes. If you have fans or you have excessive dehumidifier use or you're around smoke, these can cause exacerbations of the symptoms that you're having. The other thing that can make your eyes more dry is if you spend a lot of time on the screen or reading even like a newspaper or a book. When you focus on something up close, you tend to blink less, and so therefore you aren't windshield wipering your eyes and your eyes can dry out. So I always say take blink breaks. If you follow the 20-20-20 rule, Every 20 minutes, look at something 20 feet in the distance for 20 seconds. Kind of close your eyes, give your eyes a little bit of an eye break. Sometimes that can relieve some of that blurriness that you're having when you are focusing. There are other causes that are associated with dry eyes. Sometimes certain medicines, like if you take a lot of allergy medicines, it dries up your sinuses. It can also dry up your eyes. Some surgeries, and then systemic diseases like Sjogren's can make you more prone to dry eyes. And these symptoms can also fluctuate with the seasons. I don't know if you've noticed, since we've had to turn all of our furnaces on, if your eyes have felt very dry, because mine certainly had, and I'm about ready to start my humidifier. And then other people sometimes they don't produce a good quality tears. They either don't produce enough, or they don't have good quality tears when they're actually trying to make the tears that are lubricating their eyes. The best first-line treatment is just using artificial tears. So these are over-the-counter. They'll say artificial tears, or they'll say eye lubricants. Good brands are like Refresh, Sustain, Blink. I always say use what you feel is working best for your eyes. Avoid those get the red eye drops out. Those can end up causing more problems down the line if you use them too frequently. And then some patients actually will need prescription eye drops or like punctal plugs to help with their dry eyes. So another common problem that I see weekly is a stye or a chalasia. So these are the painful or sometimes even painless bumps you get along your eyelids. They can be associated with redness, swelling, increased tearing, or crusting. So in your eyelids, you have oil glands that line kind of like this. They line your upper eyelid and they line your lower eyelid. And those are oil glands that help release that component to your tear film to help make you have good quality tears. And so what happens when those get blocked, they get backed up and the oil can leak out and cause the bump. And you can have an inflammatory reaction, which causes all of the symptoms. The best thing when you first get one of these is heat. So my favorite is something like this. It's just called a dry eye mask. You can get it anywhere over the counter. Some people like to use a warm washcloth. If you're going to do that, just make sure it's a clean one and you're not reusing it. But you can pop these in the microwave for about 15 seconds, hold them on your eyes for about 10 minutes, and that can really help loosen up those oils. If you think of it like butter in a fridge, if you need to melt the butter, you need the heat, and then it's nice and liquid, and then for your oil glands, the oils will flow and help lubricate your eyes. And then there are some studies that show like omega-3 fish oil supplements or flaxseed oil can help that tear quality, that help improve that. Some people feel like that really is helpful. Others, my patients have shown no difference. I always say if you're going to start it, make sure you're working with your primary care, that you're not taking any supplements that are interacting negatively with any of your other medicines. Okay, so cataracts. So cataracts, if you remember back to that initial photo, you have your lens, and that is clear when you were born. And as we get older, it adds layers to it, and so it gets cloudy. Now, this is a fairly advanced cataract. This is the type of cataract where somebody comes in and they really can't see. This is not the typical cataract that I take out. I'll have some pictures later to show you more. But the typical classic symptoms that patients have when they start having a cataract is blurred distance vision that we cannot correct. They notice decreased contrast sensitivity. They can have some distortion or like glare around headlights or halos around headlights at night. Some people even have double vision or some ghosting of images because the light's not getting through that dense cataract as well. So cataracts, we'll start with the picture. So these, if you look here, this is just kind of like what a nice clear lens looks like, and this is the progression of a cataract. So, here, A, B, C, D, E, even F, you might not notice a significant difference in your vision. When I look into your eye with my slit lamp or my eye microscope, I can see these color changes in your lens. And so that is when I can say, like, we do your vision testing, we say, yes, your vision is affected, your cataract looks something like this, you feel like your activities of daily living are affected, and then we talk about cataract surgery. Cataracts typically start developing after age 60. However, it is very lifestyle dependent. They can develop earlier, depending if you have diabetes, you've had trauma, you smoke, you've had a lot of sun or UV exposure, frequent steroid use like prednisone topically or orally, and even genetics play a big role. Can help factor into the progression of this. I've had a very wide range of when I've had to take cataracts out of patients. So the treatment, initially, we can usually update your glasses because some of these changes in the lens will cause a myopic shift or that negative shift in your glasses. And that once we change your glasses, we get you back to perfect vision. Eventually, the changes will become so great that we can't correct for it, and then we have to start talking about cataract surgery. We typically do it when your activities of daily living are affected, not just because I look in and I was like, oh yes, that cataract looks like it's ready, because people surprise me all of the time and how well they can see with some of the density of those cataracts. And this right here is called an intraocular lens, or an IOL. This is actually what we put inside of your eye to help you see. So once we take out that lens, we put this artificial, usually acrylic, there's silicone, there's acrylic, there's different materials, lenses in your eye. And so that is how you can see. If we don't put something in, you have to have the Coke bottle glasses to have that much power to be able to see well. Now, fun fact, so how do they figure out how this could stay in your eye? I think it was, I'm not quite sure, remember which war. It was World War I or World War II. I think it was World War I. They had the fighter pilots, and they had glass on the planes, or this polycarbonate material, and some of the pilots would get these shards in their eyes, and they noticed that the material inside the eye did not have any inflammatory reaction. So therefore, they realized they could use this material to their advantage, and they could put it in a patient's eye, and they don't react to it. So once this lens is in, it can stay in for the rest of your life. So moving on, so we are going to talk about, this is dermatochalasis. All that means is excess or redundant eyelid skin. So this is what I'm talking about, where you have eyelid skin. It's resting on this patient's eyelashes. It's kind of causing the eyelid to droop. It can, and these symptoms patients can exhibit is they can have decreased peripheral vision. They can feel like their eyes are tired or heavy because they are being weighed down. And some people even get a brow ache because they're using their eyebrows to constantly raise up their eyelids to try to improve their vision. Once again, the biggest risk factor for this is age. Gravity works against us all. And family history and genetics, your bone structure, your facial structure can really affect if this is something that needs to be done. For this, treatment is surgery. It's surgery in certain circumstances. It can also be medically indicated or covered by insurance because we show that it actually, removing that extra skin significantly improves your peripheral vision, and that's when insurance can cover it. People also get these for cosmetic reasons. It's the same surgery, just how it gets covered or if it's not covered. Typically, with this surgery, once we remove the skin, you have a lot, people notice a lot of bruising and swelling for the first couple of weeks, but then we've removed the extra skin. It's not resting on their eyelashes. They really notice an improvement in that peripheral vision. So then for the next few slides, I'm going to be discussing flashes and floaters. So we're going to start with flashes. So when I say flashes, I'm talking about flashes of light or lightning streaks across your vision, and they look like fireworks. When these are unilateral or just in one eye, this can be caused by, if you rub your eye really hard, that's that eye rubbing, you can probably get some light changes. Sometimes it can be also caused by vitreous traction. I'm going to go into that more in depth on the next slide. People sometimes also notice flashes of light if they have retinal tears or retinal detachments. Now, if you experience these, or somebody who experiences migraines with aura, sometimes they get bilateral kind of flashing lights that move across their vision. This photo shows what patients may see if they have a migraine with aura. They get these bright lights, some fogginess. It can move across the vision, have little starbursts, and these are usually bilateral and in both eyes. When we talk about floaters, Floaters are the black specks, like little black bugs, dots. You can even see wavy lines or cobwebs across your vision. You get these because of vitreous synuresis. I'll explain that in a minute. A posterior vitreous detachment. It can sometimes even be caused by inflammation or infection in your eye. So looking at this photo, this is the inside of the eye. Inside the cavity, this, if you think of it like a ball, there's something called a vitreous. That's the jelly of the eye that helps form the eye. It is firmly adherent to the retina and the optic nerve. Over time, that vitreous collapses in on itself and will pull away from the retina, and that is normal. When it pulls away, sometimes it tugs on the retina, and that's what can cause a flash of light because you're stimulating the retina. The retina, it can only sense light, so anytime it's excited, it just is going to see light. Now, if you think of the retina like wallpaper and the vitreous is attached to it, when the vitreous comes away and it comes away cleanly, it can be called a posterior vitreous detachment, and that is normal and that is okay. That is when you might have this little condensation in the vitreous where when the light comes in, it hits that condensation and it casts a shadow on your retina and you see a floater. However, if the vitreous is attached to the retina, like the wallpaper, and it pulls and it tugs, sometimes it can cause a retinal tear when it comes away. And so that's another reason why you might see a flash of light. All of these changes we see more commonly with more birthdays, trauma, certain surgeries, and people who have a longer eye are more prone to having more floaters. So flashes and floaters are not always something that is scary or requires urgent evaluation. However, if somebody you know or yourself, you have many new floaters, continued flashes of light in one eye, or curtain shadow, or even bubble over across the vision, this is symptoms you should discuss with your eye doctor just to make sure they want to, if they need to see you in the acuity of when they need to see you. Typically, when I see my patients, I do a dilated retinal exam, and the treatment depends on the cause. And so, for instance, if it's just a posterior vitreous detachment, we usually just watch because there's no retinal tears. If there's retinal tears, we usually need to laser it. And if there's a detachment, we send you to a retinal specialist to help you get that fixed. Okay, so glaucoma. So what glaucoma is damage to the optic nerve. So the optic nerve is this cable. This is just the end of it that connects your brain to your eye, what we kind of talked about before. And when it becomes damaged, that is what we call glaucoma. And for some patients, early damage, they do not notice because it affects your peripheral vision first. And so when your peripheral vision is way out here, you may not notice that you're missing a little bit of your peripheral vision. However, in severe glaucoma, patients will notice this. They can have severe visual field or peripheral vision constriction or even blindness sometimes. There are many risk factors for glaucoma. You can have it's dependent on your family history, your race, your own medical history, the actual thickness of your cornea, age are all risk factors for this. We diagnose glaucoma based on your optic nerve appearance and certain tests that we get while we're in clinic. So if any of you are a glaucoma suspect, have glaucoma, and you've taken a visual field, you probably do not like this test. This is a visual field test. It tests your peripheral vision, and this is the chart that gets sent out that I look at. So right here, this is a visual field of your left eye, and I know that because everyone has a blind spot. This is where your optic nerve is, and that's your blind spot. And so if you have glaucoma, you might notice we might have big dark spots missing here or here, and so we can test your peripheral field with this visual field. And for glaucoma, there are many treatment options. Most people think of glaucoma as a high eye pressure. That's not necessarily true. What it means is we kind of discussed it in that terms because the only way we know how to slow down the progression of the optic nerve damage is to lower the eye pressure. So we can lower that with medications, typically eye drops, or we can do laser surgery where we laser the drainage system to lower the eye pressure. Some people who have more severe glaucoma need bigger incisional glaucoma surgeries. And in some people, they also can have the option at the time of cataract surgery, we can do combination glaucoma cataract surgeries. Age-related macular degeneration is a disease of the central retina. So your macula is the center retina where your perfect 20/20 vision is. And this disease affects that area. And when it affects, your most sensitive area, you can have some vision loss. However, most people at the early signs of macular degeneration do not notice any changes. They're very asymptomatic. When it progresses, some people might notice some blurry central vision or distortion. And in more severe cases, the vision loss can be severe. This picture is an Amsler grid. So typically, this Amsler grid, when we give it to you, it is just the squares, and they are all straight. And this is demonstrating what a patient sees those squares to be. So they see some darkening, they see some distortion where these lines, which are straight, but to the patient appear wavy. And that's what I'm trying to demonstrate for the Amsler grid. This is what macular degeneration can look like for patients. Risk factors for macular degeneration are numerous as well. We don't actually have one known cause of macular degeneration. It is much more common in people who smoke. That is a big, big risk factor. Family history can build on top of that as well. However, there are patients who have no family history and they have never smoked anything in their life and they can still develop this. The statistic is about 10% of people over the age of 50 have some type of macular degeneration, but only 10% of those have this more severe forms. And then for macular degeneration, you've probably heard of wet or dry. I'm going to get into that in a little bit, but those are kind of the two big categories of macular degeneration. I'm going to start by showing you a picture. So this is what I look at and see when we look inside of your eye. So this is your optic nerve. So if we're going to go back a couple slides, this is what I'm looking at when we are looking for glaucoma. I'm looking at this part. When we look for macular degeneration, this is your central retina. I'm looking at your macula here. This is a healthy eye. This is demonstrating a healthy eye. For dry macular degeneration, we have these little flecks here. This is representative of something called drusen. Drusen is the characteristic hallmark of dry macular degeneration. What it is a buildup of waste products that your retina is not adequately pulling out and disposing of. So it builds up in your retina, can cause damage to your retina cells. That is what this is representing. And then for wet macular degeneration, you get bleeding. So wet macular degeneration, you get new blood vessels that form and they bleed, and people can have more significant visual field loss. Okay, so dry is the most common. About 80% of people will have dry macular degeneration. It is mostly characterized by those yellow drusenoid deposits. Those can also be in wet, but that's kind of the hallmark of when we see macular degeneration. We don't have any specific treatment for those drusen. There are big studies that show that the AREDS2 vitamins can help slow people's progression for certain types of macular degeneration. It's a mixture of over-the-counter supplements. And the biggest thing I recommend for my patients who have any sort of retinal changes from macular degeneration, really stop smoking, avoid smoke exposure, eat a healthy diet of antioxidants, green leafy vegetables. Those are the things that have been shown to really help with your eye health. And then if you have macular degeneration, you can look at one of those grids and you can see if you have any changes. Then you can let your eye doctor know if you've noticed anything. For more advanced dry, let me take one step back. Dry macular degeneration can be separated into early, intermediate, and severe. For very severe dry macular degeneration, you can have significant atrophy or just loss of the retina layers. And there are some injections that some retinal specialists will use for that very small subset of patients. However, that's the only injection for the dry form. Now, people classically think of injections for the wet form of macular degeneration, where it's much more common. So as we said before, the wet macular degeneration is where you have those new blood vessels that form and they bleed and they leak, and the vision loss is typically much more rapid with this. Those injections into the inside of your eye, into that back part, target those new blood vessels, target the signal that's telling your eye to make those new blood vessels to help decrease the blood vessel formation and help reduce the bleeding that has occurred and help improve the vision. The treatment is the same as dry in the sense that we still would recommend those, AREDS 2 vitamins, not smoking, avoiding smoke exposure, having a good healthy diet. Some people very rarely will get laser with this, but the mainstay of treatment for wet macular degeneration are injections into the eye. So diabetic retinopathy is something that affects a lot of patients. Patients with type 1 or type 2 diabetes can develop retinal damage from their diabetes. So diabetes affects the small blood vessels throughout your body. So a lot of people will get like numbness in their feet because the small blood vessels to the nerves in their feet are affected. You have very small blood vessels inside of your eye, which can also be affected by diabetes. Most patients with early diabetic changes probably don't notice any difference with their vision. However, some people still might notice some blurry vision. They might have fluctuating vision because as your sugars fluctuate, if you have really, really high sugars, really, really low sugars, that can actually cause your cornea and the lens to swell a little bit, and it actually changes your glasses prescription. So your vision can really fluctuate a lot if people are having uncontrolled sugars. Sometimes with diabetes, you can also get fluid into your retina, and that can cause some blank spots or some distortion, and sometimes vision loss. Biggest risk factors for diabetic retinopathy is duration of disease and high A1C or high sugars. So the longer you have diabetes, the more likely you are to have some type of changes into your retina. And if your sugars are really high, you're putting a lot more stress on those little blood vessels. So you might have a lot more, you're more at risk to have issues with your blood vessels if your sugars are really high. So, typically, once a year, a dilated retinal exam is recommended for all my diabetic patients. Other factors that kind of will also play in is if your blood pressure is really uncontrolled or you have, your genetics that can play a factor in your likelihood of developing diabetic retinopathy. Now, just because you have diabetes, it doesn't mean you're going to get diabetic retinopathy though. So this is another photo showing a normal eye here. So what this is trying to demonstrate is that these vessels are straight, there's no bleeding, and there's no leaking. So here what happens is when you have a lot of stress on your eye, you can get these little dilations in your blood vessels. You can get little bleeding spots around them. Sometimes those little spots can leak and you get these exudates in your retina. And sometimes if you get really severe diabetic retinopathy, you can get new blood vessels and you might actually need injections or lasers for your eye. The best thing to do is to keep your eyes healthy is to maintain good glucose and sugar control. Make sure if you have an elevated A1C, getting it into acceptable range with your age and your primary care doctor thinks it's a good range. Maintaining a balanced diet with consistent exercise. Moving the body is always good. It's good for your keeping the sugars level. It's good to prevent fluctuations, even if it is just going on a walk. That's always good for you. And I already kind of touched on some of the treatment, but some people even need more advanced retinal surgeries if they get significant disease. All right. So some of the best things you can really do for your eyes is eat a nutrient-dense foods with vitamins, antioxidants, and omega-3 fatty acids. Wearing sunglasses when you're out in the sun to help prevent that UV exposure. Reducing your screen time or giving yourself those blink breaks are really good things to help keep your eyes comfortable. And making sure you get your routine eye exams at the schedule that your eye doctor says. These are the McFarland Eye Clinic Center locations if you are looking for a wonderful eye care provider. I want to thank you for your time and attention. I will take questions, and this is called a Christmas tree cataract, which I thought was very appropriate for this time of year. And then this is my fur baby, Bruce. And go Hawks.
Oh, hey. We didn't agree to that. All right. Well, I have the microphone, so I will go around to whoever has questions so that everybody can hear what the question is. So if you have a question, here we go. I'm going to have to dock her pay for that comment.
Is an OCT help diagnose whether you are developing macular degeneration?
It can. So for macular degeneration, when I look into the eye, I can see changes of macular degeneration. But what an OCT is it uses different technology, and you can actually differentiate the layers of the retina. And so those drusenoid deposits that I'm seeing on exam, we can see in the OCT. What the OCT does is it lets me see actually that photoreceptor layer, which is like the layer that gives you your perfect vision. So we can see. So yes, it does help us sometimes detect really early changes, if not just like monitor those layers of the retina that we cannot see with our naked eye.
Thank you.
Mm-hmm.
Here's another question.
Can dry macular degeneration progress into wet macular degeneration?
Yeah, so dry macular degeneration can progress into wet. It just very much depends on your eye, but yes, people can start with dry and it can progress to wet. It doesn't always happen though.
I checked there. As of right now, there are not any questions online. We'll give a couple more here.
Could you address blepharitis?
Yeah, so blepharitis is, let me go back. So some people, so what happens? So blepharitis is a buildup of debris right at the base of the eyelashes. And so what happens with that is it can cause a lot of issues. It can cause irritation to your eyes. It can irritate those oil glands in your eyelids. It can cause your dry eyes to be worse. Patients who have significant blepharitis, they sometimes will need some treatment. Typically, you start with like over-the-counter OcuSoft little eyelid towelettes or the tea tree towelettes, or some people even just use baby shampoo, and that helps decrease that burden of buildup or debris. Now, you might have heard Xemdi. I think they have advertisements on the TV that targets the mite. There's a little mite, a Demodex mite, that can sometimes cause that buildup. And so some people require a prescription drop that will eradicate the Demodex mite if the other treatments aren't successful. Does that answer your question? Okay.
I've been told that I have large cups. What is that referring to?
Okay. So for glaucoma, when we talk about looking at your optic nerve, if you think of your optic nerve, when I look into your eye, it looks like a donut. Okay? So you have the donut rim, and then you have the hole or the cup. So patients who have more cupping, that means that sometimes that's more classic of a glaucoma. If they have glaucoma, they're a glaucoma suspect. But some people, that still is a healthy optic nerve, and that's just the way they're made, and you might just have a large cup. But that's what they're referring to, is they're actually referring to your optic nerve appearance when we look into the eye, that hole in that donut is a little bit bigger than average. That's what cupping means.
Any other questions? Oh, here we go.
I probably won't pronounce this right, but it's
I've been told it's a genetic disorder, and it involves the cornea. I don't know if it's called cornea dystrophy or something like that, because my mother has it, I have it, and just recently my daughter was diagnosed with
Fuchs?
it.
Is it Fuchs?
I haven't heard that term with it.
Okay. Anterior basement membrane dystrophy? Keratoconus?
Not quite. Those don't hit the...
There are a lot. Okay, continue with your question.
Well, I'd say my mom had,
Yep.
she's almost blind. My mother's going to be 102.
Okay.
And she
Yeah.
has not totally blind,
Yeah.
but partially blind. And the reason why is because she chose not to have cornea surgery.
Okay.
So I don't know where that falls in line with what it's called, but I know it has dystrophy on the end.
So there are many different types of corneal dystrophies. One of the most common is Fuchs corneal dystrophy. What happens with that one is sometimes they start with prescribing like Morrow drops, like or Morrow 128. Does that sound familiar to you?
I haven't ever had to take anything
Okay.
yet.
Well, what Fuchs is if you think of your cornea, there's a thickness to it. You have the surface, you have the stroma or the body of it, and then at the base you have these cells. And those cells, their job is to keep your cornea clear. They pump out the fluid, and that's what keeps your cornea clear. And so you have a certain number of cells for a certain area. And then there are some patients whose cells, they said, I don't want to work. So they have fewer cells for the same amount of cornea that are working overtime to try to keep that cornea clear. And over time, they can't keep up. So the cornea can get cloudy, it can get really scarred, and eventually can cause a significant amount of vision loss, even blindness from that. So that could be that, but that's one of the more common corneal dystrophies. But there are a lot of corneal dystrophies that we see in families. That's one of the more common ones.
Then I have another one.
Yeah.
I have nicked my cornea a couple times. Now, is that going to cause any problems with having cataract surgery or anything else?
So like a corneal abrasion, no, your cornea heals very quickly. And for most patients that once it's healed, I can't even tell if you've had a scratch there before.
Okay, thank you.
Is there a relationship between the pigment in your eye and macular degeneration? And then what other foods besides the leafy greens do you recommend?
So when you say is a relationship between the pigment in your eye and macular degeneration, so the layer of the retina that is affected by macular degeneration, there is actually something called the retina pigment epithelium, and that layer can drop out. So we can call it RPE or retinal pigment epithelial dropout. I'm not sure if that's what you're talking about, but if that drops out, that's kind of the support cells for your photoreceptors. So once that goes away, the photoreceptors die off. And then for green leafy vegetables and fruits, honestly, everyone has a lot of preferences for fruits and vegetables. So I always say do your best to try to get the most nutrient dense food you can. Eating whole foods is always the best thing you can do. Rather than like less processed is always an option, if obviously that's the only thing you can have access to, but having more whole foods is always going to be better. Specifically, find something you like and try to eat a more balanced diet. I say more color, the better.
I wanted to ask about doubling.
Okay.
If I look at the full moon, I see like a moon and a half.
So there's a lot of different causes for double vision. If you're having more constant double vision, definitely talk to your eye doctor. But sometimes that ghosting, and that to me sounds more like ghosting, it can be caused by dry eyes. You need to update your glasses. It can be caused by cataracts. Sometimes your eye muscles aren't aligned right on your eyes, and that can cause, instead of being straight, one eye can be drifting and you get a little bit of a double. So it's very much variable, and it also depends on if it's, one eye, or you see double only with both eyes, or if there's a lot of different workup we have to do if somebody is having more constant double vision.
I'm going to ask a question. I'll get you after this. So you're going to learn a little bit about me because we've realized that my eye doctor who retired, Dr. Morrow, took over for, so I'll be seeing her here at some point. So after having a year ago, I had a pterygium removed. That doctor, the cornea specialist, when we talked about my eyes and dry eyes and burning, and I made a few comments. He goes, "Oh, Vicki, some people with ocular rosacea, I have to keep on this antibiotic all the time." And I was never diagnosed, but it seems to help what he's doing. So that's great. So did that ocular rosacea contribute to my pterygium? Do I have to worry about that coming back?
So pterygium is a growth, so for everyone else, is just like a kind of growth of like fibrous tissue that grows over the clear part of your eye or the cornea. And sometimes it can cause vision problems, so they remove it. That is very separate from the ocular rosacea. Pterygium, most of the time develop in people who are in the sun a lot. It's very common with people who are in the equator areas of the world. And obviously we have a lot of farmers here who spend a lot of time in the sun, so we also see them a lot here. For ocular rosacea, that goes back to your eyelid margin, and you get fine little blood vessels and inflammation around the eyelid margin, so you get really bad dry eyes. So doxycycline is the medicine that people typically are started on, not because of it's an infection, but doxycycline actually has some anti-inflammatory properties when you take it long term.
Okay, thank you.
I have excessive tearing in one eye fairly often. And eye drops used to help, but now it seems like it's not going away. Where I used to use eye drops a couple of days and it'd go away.
So sometimes that could mean, so just because you have tearing, that doesn't mean always your eyes are dry, but excessive tearing is sometimes associated with dry eyes. Other times it can actually be due to your eyelid isn't positioned correctly, so when you blink, your tears are not being directed to your tear drainage system. And then sometimes people have actually clogged tear drainage systems, so instead of going down the drain, it just falls over your eyelid and down your face.
I have one more, and at the time I had this done, I didn't think to ask why this happened. I had a calcium deposit removed from underneath my eyelid. What causes that? Or
do you mean like kind of like inside?
Yeah, you pull it back and there was a
So some people,
on my eye.
We call them concretions, and some people just develop them. People get like lipomas or little dimples around their body. Sometimes you get concretions in your eye. If they're well covered and not causing problems, we usually can just leave them alone. Sometimes they cause problems, we have to remove them.
Yeah, it was scratching on my eye.
Yep.
Isn't that interesting as we get older? Sometimes you go to the doctor and they just say, "Oh, that just happens," and we don't know why. The older we get, the more those things come up, right?
The joys of more birthdays.
What's the role of vitrectomy with the diabetic retinopathy?
I'm sorry, I did not hear your question.
The role of
Vitrectomy.
Oh, vitrectomy? Okay, so some people who have very significant diabetic retinopathy will get those new blood vessels that bleed, and it'll bleed into the vitreous, so that jelly part. And if you think of blood inside of the eye, it's like a snow globe, and it's just swirling around with red blood cells, and people can't see out. So sometimes it settles down, and it goes away by itself, and you don't ever need a vitrectomy. Some people need a vitrectomy to go in and get the blood out. Sometimes you have to do a vitrectomy if you have a retinal tear or you have other reasons that you need to go in and like reattach the retina, see the retina. That's the role for vitrectomy, more specifically for diabetic retinopathy sometimes, but it's not always the case.
Can you tell us a little bit more about cornea transplant surgery and focus on the word transplant? That scares me to death.
Okay. I don't do corneal transplant surgery, so those are surgeries for corneal specialists. Going back to the cornea, if you think of the layers, for corneal transplants, you can sometimes do a full thickness or like complete corneal transplant, or sometimes you can just transplant like the inner layer or the outer layer. It just really depends on why you're getting a corneal transplant. So what they do is they take donor tissue, just like they take heart, lung, skins from a deceased donor who has so graciously said they will supply the world with their organs after they have passed. And you take the tissue and it goes through a variety of tests to make sure it's safe to use and it's sufficient enough cells and it's healthy enough. And then they remove the diseased part of your cornea and they put it in. So when we go back to Fuchs, one of the more common corneal transplants is they just scrape off that unhealthy layer with those cells that aren't working. And there's a little scroll and they unscroll a new inner layer and it reattaches with the bubble. And then that helps supply your cornea, so it helps keep your cornea clear.
How long does this transplant tissue tend to work? It's already been used and and donated. So is it in good condition or what? Well, you're saying it is in good condition, but do you expect additional surgeries, repeated cornea transplant surgeries?
That is very dependent on why you get it. So, for instance, people who had keratoconus and they got a full thickness corneal transplant, sometimes even in like the 90s. And I'm seeing them now, sometimes they still have their original corneal transplant. So they can last a really long time. Some people, if they're getting a corneal transplant because they had a terrible infection or inflammation, sometimes those may not last as long. So it's very dependent on your body, why you're getting the transplant, and there are standards that all tissue has to meet before they're allowed to be donated, and they're very strict on how they process those tissues. I've actually was able to go to the Lions Eye Bank in Iowa City when I was in medical school there, so they do a lot of really detailed analysis of that stuff.
Can I ask another real quick one?
Yeah.
What do you have to say about tattooed eyelids?
I see a lot of people who have like tattooed eyeliner. Honestly, it doesn't really affect their eye health too terribly much. If someone's going to get a tattoo on their eyelid usually it's like tattooed eyeliner is what most people want. Make sure you're going to someone reputable, know that there are risks of infection, and make sure that they are, doing everything sterilely so you don't get an infection. As with any processed tattoo anywhere on your body, if you get an infection, you can get an infection in your eyelid. But I see plenty of people with that do fine. I think it just, if you want to take the risks and you're going to somebody who's done it a lot and does it sterilely is the big thing.
And there is one question online. Tim, if you would read that.
Sure. The comment was the dilation solution was too strong last week. She couldn't see for 24 hours. She says it was horrible driving home when oncoming lights were blinding me. 1 year, I couldn't see for 3 days. Could you explain the levels of solution for dilation?
So typically for dilation, the dilation that I drop I use on most of my patients, it's a combination of two. It lasts 4 to 6 hours. Most of the time, dilation really only affects your near vision, but it can make you a lot more light sensitive because your pupil's really big, so there's a lot of light coming in. Those are the dilation drops that I typically use. Now, some people are more sensitive and they feel off balance for a little bit more, but those dilation drops that I typically use are usually 4 to 6 hours. Now, for children, like little kids, like they're 2 or 3 who can't tell me 1 or 2, I have to use something called a retinoscope in their red reflex to basically get their glasses prescription. I have to use a stronger dilation drop for them, and that can last, 24 hours. I never use that on a normal routine eye exam. And then there's another dilation drop that I only specifically use if somebody has inflammation in their eyes, and I never use that for just like a routine eye exam. So yes, there are different levels of dilation, to a few hours to even up to a couple of weeks. But we don't use those long-term ones for just routine eye exams.
So as somebody that is going to be a candidate at some point in time for cataract surgery, I was talking to a friend and she said like the lenses choice that you have are like either to have a lens that you would see better close or far, or you can do one of each in, in your eyes kind of thing. Is that something that's done?
So there are a lot of intraocular lens options that we can put into the eye. Now, the one that gets put in majority of patients, it is a monofocal lens, meaning it's set at one distance. That gives you very good, usually, distance vision. And everything kind of computer up here, you usually need reading glasses for. Patients, if you remember, I talked about the monovision contacts, one eye for distance, one eye for near. Patients who have done that successfully with contact lenses are candidates for doing the same thing for cataract surgery, where we set one eye for distance and one eye for near. Now, some people who have an astigmatism, you have to have the right kind of astigmatism. We can put lenses in that correct for the astigmatism, so that's an option for some folks. And then there's something called advanced technology lenses that can sometimes give a little bit more range. So you get distance, some computer. Near is a little bit iffy. Kind of depends on the lens. Now, just because we have those options, it doesn't mean you're a good candidate for them, because there's a lot of factors that going into if that technology is going to work into your eye, the health of your cornea, the health of your retina. There are financial factors to consider, as those other lenses are out-of-pocket costs. Insurance doesn't cover them. I think that each option has ideal patients for each, and so when you get to the point, you can ask your cataract surgeon to talk about them and what they think would be best for your eye. There's so many, and we could talk about it for a really long time, but there are a ton of lenses that we can put in the eye.
And I just want to reiterate, because I recently had a conversation with some people about this. So isn't it the monovision type, the basic is what usually insurance will pay for. And then if you want anything where you have the both options available, then it's out of pocket for you at that point.
Yep. And it's, insurance covered once you met your deductible and all of that. So it's not just free. It's, if your insurance and what your insurance covers and deductible, but it is covered. And then the other ones are an additional fee if you're the right candidate.
Any other question here?
What causes light sensitivity?
That is, I can't answer that specifically. There are a lot of reasons people can be light sensitive. Inflammation in your eye can cause you to be light sensitive. Dry eyes can make you feel light sensitive. People sometimes with lighter color eyes, like light blue eyes, can be more light sensitive because there's less pigment blocking the light in. When your eyes are dilated, that can cause you to be more light sensitive. Those are usually some of the bigger ones. It's just some people just are more sensitive to light than others. And some of them are just your eye, and sometimes there are some medical causes.
And any other questions? Oh, here we go.
When you do get your eyes dilated, they used to give reversal drops. Why don't they do that anymore?
So they don't do it anymore because sometimes when you have that muscle that is dilating your pupil and you pull it back, you can increase risk of retinal tear. I think they might be working on some new drops that are a little different, but I think that the whole time in my training, they've never had them. So I think they have like some risks for some bad side effects. Even if it's uncommon, most people find that unacceptable.
Any other questions? Tim, any other ones online?
Nope.
No? All right. Well, it looks like we got it all covered. Lots of great questions. And Dr. Morrow, thank you so much for a great presentation. Yes. You covered a lot of information, answered a lot of questions. Oh, I don't know. Tim, can you color in those jerseys up there?
Junior and Bruce. Yeah.
You have a fellow Hawkeye fan.
Yeah.
Well, thank you again so much. As a reminder,
thank you.
As a reminder, please fill out the evaluation form and also give us ideas for other topics and presenters you'd like to hear from. We do have another program tomorrow down at 60 Forward. Please know that it's full. It's the program that is on AI, and it's been full for at least 3 weeks. That's one of the challenges. We love doing programs down there, but they can't hold as many people as we can here. But you can, if you let me know, I can still send you the link that you can attend virtually, or you can watch the recording at a later date. And then after that, our next program is our annual holiday gathering out at the Gateway. That is Tuesday, December 2nd at 1 p.m. So make sure you get signed up for that if you'd like to join us. We'd love to have you there. We're going to have some great entertainment. We have some carolers that are coming, that they dress up and they're going to be wonderful. And other times of the year besides the holidays, they are a pirate quartet. So I think they will be a lot of fun, and we hope they'll sing a pirate song or two for us, as well as some great holiday songs. So thank you for joining us, everyone. Please drop off those evaluations in the wire basket on that basket on the back, and have a great day. And once again, thank you, Dr. Morrow.